Okay, is everybody seeing a single slide?
Yes.
Yes.
Okay, good, good. So thank you for the invitation. I am going to talk about, and thanks everybody for logging on. I'm going to talk about kind of this evolution our field is taking to very personalized care of vulnerable populations of various sorts, and talk about IBD in older adults. So it's interesting because we think of IBD more in terms, when we start to think about therapy and what therapeutics we're going to use particularly, we think more of in terms of disease phenotype. So does the patient have Crohn's disease versus UC? If they have Crohn's, is it ileal or colonic? Is it fistulizing disease or not? And we use the phenotype to kind of help us in our medical decision making. But the patient brings a lot of attributes to the table, things like age, gender, race, cultural nuances, all sorts of things. Health literacy is a big one. And if the pandemic taught us anything, they bring politics to the table. So all of these things need to factor in the way we talk to patients, the way we explain things, what drugs we choose, and how we take care of those patients. So it gets more complicated than just looking at the disease phenotype. So our new approaches with this personalized care is to kind of meet patients where they are, consider all the patient attributes that the patient brings to the table, disease-specific ones and other ones. We engage patients in the process. We acknowledge and try to mitigate potentials for bias. And then we focus on effective communication. And with this approach, we can, I think, do a lot of good for our patients and help in some of these more nuanced situations that arise. So we're all aware of that classic graph in the lower right corner about the onset of inflammatory bowel disease. These are diseases really of, second and third decade of life. These are diseases of 20 somethings. And so most of our focus is on adolescent and young adults as far as a vulnerable population, or young adults and trying to get educated, trying to start jobs and have families. We see this, we used to call it a second peak in patients in their 40s and 50s. Now what we're talking about is IBD in elderly patients, and this would be patients over 65. So baby boomers in the US, the second largest population group in 2022. It's almost 70 million people are age 58 to 76. So perhaps no one else on this call, but I am a baby boomer. 25% of newly diagnosed Crohn's patients are in this over 65 age group. There tends to be kind of a little bit different from IBD onset at younger age, a female predominance of about 2 to 1. And this 25% is gradually increasing over time as our population gradually ages. So taking all comers, all IBD comers, about 15% of IBD patients are over 65, but they're overrepresented in hospitalized patients. So they get admitted more often than younger patients, not surprisingly. They have greater rates of hospital mortality, increased rates of infections and thromboembolic events, and increased length of stay when they get admitted. There are some interesting nuances about the diagnosis and clinical course. And I think because we're so used to this younger population, 60% of elderly patients with IBD are initially misdiagnosed versus only 15% in younger Crohn's disease patients. And there's often a delay in diagnosis in older IBD patients, taking as much as 6 years versus 2 years. So an interesting kind of epidemiology is sort of emerging. So there's an interesting concept that factors into both the expression of the disease, the course of the disease, and our therapy, and that is the concept of immunosenescence. So increasing age alters the immune system, the immune response in various ways. it increases the risk of infection, and it increases the risk of malignancy, and it affects both the innate and adaptive immune system. The other factor that's at play is malnutrition. It's often overlooked, and it also accelerates the decline of the immune system. And this is something that, thank heaven for Angela. She's brought this all to our attention. So now we're much better, I think, at watching for malnutrition and looking at nutritional parameters, both initially and along the way in IBD. And when we talk about elderly patients, this idea of being fit versus being frail is really important. And so because it to a large extent determines how the disease is going to express itself and how much, how successful you're going to be at treating that patient and how much of a risk they're going to have of complications of therapy like infections and malignancy. So if you have a fit patient with IBD, obviously you're much better off and have much easier time treating that patient than a frail patient. And you have to watch for all of those complications with more vigilance. So compared to our adolescent and young adult population, older patients are not as inflamed. They don't have as much inflammatory stuff going on. And I guess that is, sort of, not a surprise to all of us that, it's really those young patients that have all the inflammatory consequences and have that hair trigger immune system that's young and active. So, but in older patients, you see a lot of diarrhea, you see abdominal pain, but you don't see people with bleeding. You don't see people with erythema nodosum. You might have arthritis, but it's not really the spondyloarthropathy sort. Uveitis is not as common. All those things can occur, but there overall tends to be less inflammatory in the older population. Fewer patients have a family history of IBD. In elderly ulcerative colitis patient, it's more former smokers. So smoking is protective, but so if people stop in their 40s and 50s, then they can have IBD express itself later in life. In elderly Crohn's disease patients, there are higher rates of colonic involvement and less of that, less pan-enteric sort. So they don't usually have, esophageal gastrointestinal or a lot of small bowel disease. They might have ileocolonic disease, but they don't have that pan-enteric disease that sometimes we see in younger patients. They have a lower rates of perianal disease, and they don't get as complicated disease, not as much stricturing and not as much penetrating disease. So all in all, the disease is common, but not as inflammatory as it is in younger patients. So this is kind of interesting. It could be because their inflammation, and when they're older, even though it's less inflamed, it's harder to beat down the inflammation. If you look at patients that have had disease for 15 years or more, and if the patient is elderly and has had 15 years of the disease, there's a 68% chance that they have continued inflammation compared to only 29% in younger patients. I don't know about you guys, but I tell my patients, sort of the good news is that this disease does tend to sort of burn itself out with time. Turns out that based on this data, that's probably less likely to happen in older patients because their inflammation, whatever is driving it, just doesn't sort of wane with time in the same way it does in younger patients. So not surprisingly, as I mentioned, elderly patients are more likely to be hospitalized, and this is based on a lot of factors: their comorbidities, adverse effects to therapy. They don't handle disease severity particularly well, lots of incontinence, lots of symptoms, and then they're more likely to seek medical help because they presumably have been in the medical system longer for other things. And so they're better connected probably to primary care and perhaps gastroenterologist. So when they are in the hospital, their mortality is kind of shockingly high, and not, I guess it's not, an odds ratio of 17. It's, they're susceptible to C. diff and opportunistic infection and thromboembolic events. So in hospital IBD mortality is frightening. So if you have patients that end up getting admitted, watch out, because they get all kinds of different things. Therapy in the elderly is very interesting. So the bottom line, to cut to the chase, is that steroid-sparing regimens like immunomodulators and biologics are underutilized big time. And gastroenterologists are just reluctant to start their elderly patients on immunomodulators or biologics because of safety concerns. Will they get an infection? Will they get a malignancy? So 32% of geriatric IBD patients are maintained on chronic steroids. And we're not even very good at giving them calcium and vitamin D. And so, a lot of patients are on chronic steroids in elderly age group with IBD. When we look at anti-TNFs in elderly patient, there's really little evidence that there's age-related differences in efficacy. So they really probably work okay. Maybe the disease is a little bit harder to beat down in the elderly, but it works. It's pretty good. There is a twofold higher rate of infection compared to younger anti-TNF users. This has been shown in several studies. We'll talk about this a little bit more. There are higher rates of discontinuation of once they start an anti-TNF, they stop it relatively quickly. But overall, the benefits of anti-TNFs and biologics in general likely outweigh the risks, and we should be using more of them, is kind of the bottom line in the literature. How about other medications? Well, I don't have to tell anybody what the risks of chronic steroid use is, and this is, of course, heightened in this elderly population, where it just does not seem like a good idea at all to keep patients on chronic steroids. Thiopurines, in this population, there are fewer patients that develop pancreatitis. They develop more non-melanoma skin cancers, not a deal breaker in most patients, but pretty annoying, particularly here in Florida. There's a 1.5 to 5-fold increased risk of lymphomas in elderly patients on thiopurines compared to younger patients on thiopurines, or compared to age-matched patients that aren't using thiopurines. So you get that. So it's higher than younger patients on the drug, and older patients that are on the drug have increased lymphomas compared to older patients that aren't on the drug. But still, the literature really suggests that routine discontinuation or absolute avoidance of thiopurines solely based on age is not appropriate. And if you have a patient like the one Jennifer presented, if they happen to be older with perianal disease, you really should use thiopurines and dual therapy in those patients. Not a lot of data on our newer drugs. Vedolizumab, theoretically, that's the one we often use in elderly patients, particularly patients that have a history of cancer or, some reason to want to use more targeted therapy. There's limited data, but what there is comparable to anti-TNFs in elderly patients. So, there's no real compelling data that it's markedly better in this age group. There's very little data on ustekinumab. Tofacitinib, there is data from rheumatology. There's no age-related increase in really serious infections, but zoster is more common on this drug, as I think everybody knows. And of course, the increased risk of thromboembolism and cardiovascular risk in older patients was the basis for the black box warning with that drug. So tofacitinib does have some important considerations in this age group. I point out this review. This is a really nice and very recent AGA clinical practice update on IBD in elderly patients. So this is a good one to keep kind of at your fingertips and read on a, particularly boring Saturday night or something. If anyone has those, maybe no one else has those except me. I don't know.
I do.
So cancer risk in elderly patients, it's probably the number one reason why people try to avoid anti-TNFs and other biologics. Older IBD patients have increased risk of colorectal cancer and other cancers, but it's really independent of therapy. So unlike infections, which we saw were higher, with anti-TNFs at least, there's a threefold increased risk of cancer in older patients on anti-TNFs compared to the younger population. But when you age match patients, that doesn't hold up. So anti-TNFs in the older population don't cause an increased risk. Lymphoma is slightly increased with when you're age matched. So lymphomas, there is probably a slight concern, but again, you shouldn't just blanketly say no immunomodulators in the elderly population. We get asked this all the time about patients with a higher history of cancer of any type. That's been looked at pretty carefully. And patients with a prior history of cancer are at risk for recurrent cancers after they start a biologic, but it is independent of the biologic therapy. So a prior history of cancer often leads to another diagnosis of cancer, but being put on a biologic or not doesn't make any difference, doesn't make that worse. So you can, when we see patients with a history of cancer and we want to start a biologic, we do it with the oncologist on board, but I'm always sort of reassured by this data that that cancer leads to more cancer, but biologics don't impact that rate of recurrence. So polypharmacy is another issue, and this isn't really good data. There's lots of reasons why this could occur. We all know that our elderly patients are on just a boatload of medicines. I saw a patient the other day that was on like 28 medicines of different sorts. And interestingly, polypharmacy is associated with a higher HBI and lower SIBDQ. So higher disease activity indices and lower quality of life. And it's hard to tell whether that's kind of the chicken or the egg sort of thing. Are they taking more medicine because they're sick, or are they sick because they're taking so much medicine? 54% of Crohn's patients reported adverse medication reactions. And when they stopped some medicines, 10% of Crohn's patients had significant improvement, both in the HBI scores and the SIBDQ scores. So I don't think this is really good data, and it's kind of old, but I think polypharmacy is something that we really should think about. And I always think about this when we put people on supplements, or I'm not a probiotic user, but if we put them on probiotics, we put them on all these things. And then it creates this sort of polypharmacy that then has problems of its own. So the take-home points are that therapeutic challenges exist at both age extremes in our adolescents and young adults. There are challenges with medication adherence, healthcare utilization patterns, things like that. In our older populations, we're more wrestling with comorbidities and managing safety profiles. Don't completely avoid biologics or immunomodulators in the elderly, and keep an eye on your patients on chronic steroids. It's as important in this age group, maybe more important than in our young patients. Risk benefit analysis should always be performed, and quality of life is paramount in most of these patients. And it's our nuanced approach to IBD in vulnerable populations, and that's kind of the next big thing. And it's all about the team. And with you talking about older patients, we have the usual sort of teammates, but don't forget about gerontologists. They're really talented. Primary care becomes even more important. And don't forget about us, reach out to us, your UF colleagues. We're glad to talk over these patients. We've got a good team. Here it is. Um, you guys, I think, know most of these folks, so we've got a really good team that we are proud of and love. We love our surgeons. Oh my gosh, they're great. So that is my talk. Anybody have any questions?
I just say, take heart, you're not alone. I too am a baby boomer.
Okay, all right, Rhonda, I like it. Thank you. Thank you. Well,
I recently had an 86-year-old who had a new diagnosis of ulcerative colitis. And she was actually, it was really upsetting because she was initially going to GI out in the villages. And they put her on, I think, Remicade initially. And she had a really bad reaction to it. Like you said, patients with older patients with IBD tend to have reactions to some of their meds. But the infusionist, I think it was the oncologist, actually asked her, well, how much longer do you want to live? So she came down to see us, and I ended up putting her on tofacitinib, and she responded really, really well to it. And I think a lot of people are really afraid to use some of these newer agents on older patients, but I mean, they work just as well a lot of times. And I think the risk is there, but I think they still have a lot of life left, and you shouldn't be afraid to use these meds on older patients.
yeah, I think so too. I have had some amazing patients, but for every one of those success stories, I have a patient now I'm wrestling with that has horrible bronchiectasis, is on and off antibiotics, on and off steroids for that, and has ulcerative colitis that had been fairly well controlled, but now isn't. And, I want to scope him, but his lungs are so bad. And I don't know, I don't really want to escalate his therapy because he's at such risk for infection, and managing the comorbidities gets to be a big deal. And for the last 5 years, let's see, he's probably early 80s, but he has just not wanted to have a colonoscopy. He said, I'm sort of done. I'm not going to have a colonoscopy anymore. And I was fine with that until now he's getting worse, so you kind of have to wrestle with all that along the way.
That is a really, really tough call. And then those patients aren't good candidates to get their colons out either. So you're between a rock and a hard place.
No.
Yeah.
Yes. Hi. Me again. Sorry. I like the information about frailty. I think that that's getting a lot of attention lately. I got a lot of information on frailty recently from hepatology experts. I think that there's a big push also in screening for frailty at the office. And the simple clinical tool is besides labs like checking albumin, perbumin, etc. It's asking the patients to get out of get up from the chair without using their arms to support themselves. And I think that there's no data to validate that in terms of sensitivity or anything, but they said that they are using that with their patients with cirrhosis, because as they know that mortality has been linked to their frailty, their muscle mass loss that is being seen more often in patients that start developing ascites. Now, I transpose that to most of my patients nowadays, especially with my IBD patients, that they get very weak, and I pay attention when they are in the office and whether or not they are able to move around without any significant restriction, if they had signs of muscle wasting in the face or anything like that, and make emphasis also that yes, is the nourishment is very closely related to whether or not they start developing, or they are more prone of being frail. And for me, that's very important when if somebody gets in the hospital for IBD flare or something, the first thing the patient gets is they get an MPO or clear liquid diet for 48 hours straight. And so those patients, especially elderly patients, they are very susceptible to getting very, very weak and losing a lot of muscle mass in the process. So those things that we are probably not as you know, a lot of doctors, we're not used to check for those things or think of those things in the long run for these patients. So for me that was very, very important. You know, it was very, very, very cool for me to hear about the aspect of frailty in IBD. I never put the two and two together, but yes, but thank you.
Yeah, that concept of frailty has been around for a long time in many fields. I don't know if any of you guys know Seymour Katz. Do you know who that is? He's a older gastroenterologist from New York, kind of the Dan Present kind of generation. But he gave me that slide, and he's probably the best known gastroenterologist for writing and speaking on IBD in the elderly. And that slide he gave me, I've updated a little bit, but he was talking about frailty, 15 years ago. So it's been around a long time, but I think we're just kind of now catching up as a field. So, but I do agree, there are screening tools for it. And now that we know it's linked to immune response and response to therapies and complications of therapies, it's taken on more significance. So, yeah. Very good point.
Yeah, I think it's there's ways of measuring for sarcopenia on cross-sectional imaging that have been linked to post-operative outcomes. And so I think especially in liver transplant, but also in IBD, I did try to do, I tried to foray into that a little bit for IBD, but the funding for that, nutrition research is difficult, as you know.
We actually have a paper that one of our fellows, Ferris Abu did when he was a resident, but of course, then he got into fellowship at Northwestern and he never published it. So yeah, we have a study that we did. And yeah, so with using cross-sectional imaging for sarcopenia.
Oh, maybe
I don't know if it'll ever get published.
Maybe we could unearth that and push it through. I would love
we perhaps, I actually gave it to someone else in the lab. And then I contacted Ferris at the same time. And then he said he was going to do it. But I think it's like, your brain is willing, but your time is short. So
I know how that feels.
he's a super talented guy, and I think Ferris must be a third year fellow now, maybe.
I think he's graduating this year. I had heard in the eaves that he's going into advanced endo.
Yeah, I'm not surprised. But he was one of our best and brightest and got into, is he at Northwestern or University of Chicago? He's at one of those two.
Somewhere in Chicago. But yeah.
Awesome. Well, does anyone else have any other questions for Dr. Zimmerman? Thank you, Dr. Zimmerman. That was a great presentation. I'm going to send out a quick poll just for the next date. If you could all answer it quickly, which date works best for you. And then also Dr. Zapatier, I think you said you wanted to do the next case presentation. Do you still want to do that?
Sure thing.
Perfect. Okay. So I think everyone answered, and November 17th is the winner. So that will be our next date. And Dr. Zapatier will present his case presentation. Does anyone else have any questions or anything else that they wanted to say?
I do.
Oh, hi, Lindsay. Yes.
Hi.
Yeah.
Just two questions. Out of curiosity, are you going to be doing this next year? And if we participated this year, can we participate next year? That's my first question.
Good question. So that is a very timely question. I actually am working on securing funding for another rendition of Echo IBD. It actually is pretty popular nationwide. I've had multiple people from, there's people from Kansas and also people from New Mexico who have done Echo IBD and secured actually government funding for it. So I will work on it and I will let you know as soon as I hear about funding. But I love the series and I think it is so great to share information and collaborate. Our next session, if anyone wants a sneak peek, our very own pharmacist, Tim Edminster, will be doing a quick presentation on how to best make sure your patients get authorized for their medications, what kind of documentation you need, tips and tricks, things like that. And it'll be a quick rundown. And I think you had requested that, Jennifer, so he'll be making an appearance for that, and I think it'll be a great presentation. So I'll update you about that and also about our next Echo IBD. It'll be more focused on transitional care, maybe looping in our pediatric colleagues a bit and making sure we address, young adult population. So that'll be more a little bit of shift in focus, but I think something that all of us could really brush up on.
Hey, just one more question. I kind of did my presentations right away at the beginning. So I was just curious, do you need our addresses, or at this point, are we just going to get the full honorarium as opposed to the segmented that we talked about at the beginning?
Good question. We are nearing the end of the series. I think we are slated for 10 presentations. So we're very close to that. So we'll probably end up sending out the full honorarium at the very end. So good question. So lots to come as we're nearing the end of our series. But again, thanks everybody for tuning in, and we'll see you November 17th. And thanks, Dr. Zimmerman, for that
Yes,
great
thank you
presentation.
guys.
Bye-bye.
Thank you.